The next topic I'd like to discuss with all of you is retrobulbar hemorrhage, which is a really important topic, not just because it's a vision-threatening injury, but also because it's so time-sensitive. If your patient comes in and has a retrobulbar hemorrhage, they will start to have permanent visual loss within 60 to 120 minutes. And so it's very important that I teach you guys to recognize and manage these patients quickly and efficiently. I think it's easiest to divide these patients into three different groups. The first group is the patient that is awake and cooperative, and someone that can answer questions for you. So if you want to evaluate this type of patient for the possibility of a retrobulbar hemorrhage, the things you want to ask this patient about is, first of all, do they actually have pain in their eye? Secondly, you want to find out about their visual acuity. And I'm not suggesting that you take them over to the Snellen chart, but you should at least test to see if they're able to see hand waving, if they can count fingers, and if you have anything available, you can give them something to read to see how their vision is. Finally, you want to also do a physical examination, of course. You want to look for any proptosis, which is highly suggestive of a retrobulbar hemorrhage. You want to look at their pupil for any afferent pupillary defect. And if you have suspicion for a retrobulbar hemorrhage, you want to next go and check imaging on this patient. And we'll talk about that in a couple of minutes. So that's your first class of patient, the patient that can talk to you and answer simple questions. The second type of patient might look more like this. And this patient obviously cannot tell you whether they're in pain. You cannot check this patient's visual acuity. And so the things that you're left with are your physical examination. Of course, you're still going to look for proptosis on this patient. You can gently palpate their globe to see if it is tense, which is a sign of a retrobulbar hemorrhage. But of course, you don't want to palpate too aggressively in case the patient does have a globe rupture. You can look at their pupil for evidence of an afferent pupillary defect. And of course, in this patient population, imaging is going to be extremely important. So that's our second class of patient. The third class is a patient like this. So she may be able to answer questions. However, you can't examine the eye at all. So now you cannot look for an afferent pupillary defect. You cannot check this patient's visual acuity. And so imaging in this class of patients is going to be extremely important. The imaging modality of choice, if you're able, is to get a CT scan. And you want to make sure that you order the right CT scan because it's not just a CT maxillofacial. You want to specifically order a CT of the orbits. In this case, you can see very obviously here that you have a retrobulbar hemorrhage. It's clearly causing proptosis. The limitations with the CAT scan, obviously, is that it needs to occur in a timely manner, and the patient has to be stable enough to leave the emergency department. So if either of these things cannot be accomplished, your next choice is to do an ultrasound. And ultrasound is great. Obviously, it can be done at the bedside, and ultrasound of the orbit only takes maybe 30 seconds. And before I lose the attention of some of the audience members who are thinking, I can't do this, I've never been trained to do an ocular ultrasound, I want to tell you that as long as you can find the on-off switch, I guarantee that you can do an ocular ultrasound. And I have a little video here to show you. This is one of our medical students. And so what we're going to do is just a quick bedside ocular ultrasound that will help you diagnose a retrobulbar hematoma, among other things. And so what you'll see happening is there is a large amount of gel that's being applied to the patient. Hopefully you don't drop the probe on the patient. The gel does not need to be sterile, and you do not need to put any dressing over the patient's eye. What you're seeing here is you can see the anterior chamber, you can see the lens, but really none of this matters. The area of interest here is the retrobulbar area, obviously. And I'll show you what normal versus abnormal looks like. But you can see that we, in about 15 to 20 seconds, have already obtained a pretty clear image of this retrobulbar area. And so in this picture on the left side, you see what a normal retrobulbar area looks like. It's pretty homogeneous in appearance versus the patient here with a retrobulbar hematoma, where you have an area of that's hyperechoic that is indicative of a retrobulbar hematoma. Now, I understand that this finding is a little bit subtle, but I think that in the correct patient with a physical examination and mechanism of injury that is concerning, with this ultrasound finding, I don't think you'd be at any fault to treat this patient medically or surgically, which is going to be our next discussion.